Shock. Shock is defined as a widespread abnormal cellular metabolism that occurs when gas exchange with oxygenation and tissue perfusion needs are not being met sufficiently to maintain cellular function. It's more of a condition. This isn't a disease process. It's the response of the entire body when too little oxygen is being delivered to the tissues. So, when the body's compensatory mechanisms or interventions are not effective or have all been used up, then shock will progress and lead to cellular loss, multiple organ dysfunction syndrome, and death. Signs and symptoms of shock initially are very similar, regardless of whatever causes the shock. An increase in the heart rate and respiratory rate, or a slight increase in the diastolic blood pressure, are often the first signs of shock. Therefore, these being very common symptoms, it can be very easy to miss. There's four main types of shock. We have hypovolemic, which is due to too little circulating blood volume that results in inadequate total body perfusion. We just don't have enough blood volume. Can be caused by a total loss of body fluid from hemorrhage or diabetes insipidus, hemophilia, dehydration, etc. Typically, we need to have a reduction in the intravascular volume of at least 15% or more for shock to occur. Venous blood returning to the heart has been decreased and ventricular filling of the heart drops. Stroke volume, cardiac output, and blood pressure also will begin to decrease. Then we have cardiogenic shock, which is due to an unhealthy heart muscle that impairs pumping. So, what causes it? Well, we have direct pump failure, probably from a myocardial infarction, or cardiac arrest, or cardiac tamponade, ventricular dysrhythmias, or cardiomyopathies. But for some reason, whatever the cause, the heart pumping ability has been compromised, and cardiac output and tissue perfusion are not maintained. So then we begin to see a reduction in our MAP. Our myocardium oxygen is progressively depleted. With cardiac tamponade, this is basically where we have the pericardium, that pericardial sac, which is the lining around the heart. And for some reason, fluid is filling that sac, and now it's decreasing the pumping ability of the heart, or we have some type of pressure put on the heart, uh, maybe from air from a tension pneumothorax that is preventing the heart from actually working well. So we begin to have muffled heart sounds. We may see pulsus paradoxus. We may see tachycardia, hypotension, and jugular vein distension. This is really a true emergency when we do start seeing signs of cardiac tamponade. The next type of shock is obstructive. It's due to the inability of the normal heart to pump effectively, again caused by cardiac function being decreased, but this time it's decreased by non-cardiac factors. So maybe it is the cardiac tamponade where it's caused by something other than the heart muscle itself. Pulmonary embolus, that tension pneumo, obstruction of the heart or great vessels. Whatever the cause, somehow we have an impeded or impaired venous return. And the last type of shock is distributive. It's also known as vasodilatory or vasogenic shock, and it's due to blood not lost from the body, but has been distributed to the interstitial tissues, and it's no longer in the blood vessel, so it's not being perfused. Causes would be fluid being shifted from the vascular spaces, the blood vessels, but the total fluid volume is still normal, or it may even be increased. Or we have pooling in the venous and capillary beds, or capillary leakage. We can see this being caused from spinal cord injury or head trauma, anaphylaxis, sepsis, burns, pain, stress, etc. But whatever the cause, we have widespread vasodilation. So then we have decreased peripheral resistance. And despite there being no change in the amount of fluid in the body, hypovolemia does result. It's basically you have this blood volume that is going through this pipe. This blood is going through this pipe, but now the pipe gets bigger, so we still have the same amount of blood volume, but we just have a bigger space to fill, and we don't have that volume to fill that space. So despite that change, we do have the hypovolemia. Now we do have three different types of distributive shock. We have septic shock. And in the United States, sepsis kills about 250,000 to 500,000 Americans every year. And that was a 2018 figure. So that figure might have changed. It is the most common cause of distributive shock, with septicemia being the leading cause of death in the intensive care unit. It can be caused by both gram-positive and gram-negative bacteria. Then we have anaphylactic shock, which is a widespread hypersensitivity reaction, or anaphylaxis. It does cause the vasodilation, and we see pooling of blood in the periphery, also causing hypovolemia. And finally, we have neurogenic shock, which is due to disruption in the communication pathways between the upper motor neurons and the lower motor neurons. So we have an imbalance of parasympathetic and sympathetic stimulation of that vascular smooth muscle, so vasodilation occurs. Blood pools in those venous and capillary beds, and bradycardia occurs. Our central venous pressure drops, our stroke volume decreases, and our MAP falls. In the early stages of neurogenic shock, our client is going to be warm and pink, but as the shock progresses, the skin will become pale and cool. Risk factors for shock. General risk factors are going to be those individuals that indulge in high-risk behaviors, such as driving under the influence, dangerous sports, those that are going to be at risk for trauma and shock resulting from bleeding or multisystem injury. Hypovolemic shock risk factors include hemophilia, diuretic therapy, that diminished thirst reflex, immobility, use of aspirin-containing products, and anticoagulant therapy. Cardiogenic shock risk factors include diabetes mellitus, presence of cardiomyopathies, distributive shock, diminished immune response, reduced skin integrity, presence of cancer, peripheral neuropathy, stroke, being in a hospital or extended care facility, malnutrition, and anemia. And risk factors for obstructive shock include pulmonary hypertension and the presence of cancers. So, what happens during each stage of shock? Well, we have four basic stages of shock: the initial, compensatory, progressive, and refractory stage. In the initial stage, the body compensates with vascular constriction and increased heart rate. This helps keep the cardiac output and MAP within normal limits. And shock is very difficult to detect at this stage. We have a decrease in that mean arterial pressure, or the MAP, of 5 to 10 millimeters of mercury from baseline value. We also have decreased tissue perfusion, an increased sympathetic stimulation. We see mild vasoconstriction and an increased heart rate. Then we have the compensatory stage, which is also known as the non-progressive stage. This occurs when we have decreased tissue perfusion continuing, and it triggers the neural, endocrine, and compensatory chemical mechanisms to help keep that MAP and oxygen supply going to the tissues. With stabilization and interventions, the clients can remain in this stage for hours without any permanent damage. Stopping the cause of shock and appropriate interventions can prevent shock from progressing, and those effects are reversible. The cardiovascular responses are no longer able to maintain the MAP and supply oxygen to those vital organs, so now the kidneys and the hormonal compensatory mechanisms are now activated. After activation, cardiac output and MAP stay within those normal ranges. We have that decrease in MAP of 10 to 15 millimeters of mercury from the baseline value. Perfusion to those vital organs is maintained, but perfusion to non-vital organs has been decreased. We have a continued sympathetic stimulation with moderate vasoconstriction. We also have an increased heart rate, an increased respiratory rate. Now we have a decreased or narrowing pulse pressure, a decreased urine output, chemical compensation. The renin, aldosterone, and antidiuretic hormone secretion that leads to water reabsorption is now activated. Tissue hypoxia in non-vital organs will begin to occur. The client will be in mild acidosis, mild hyperkalemia, hyperglycemia, restlessness, irritable. We see a falling systolic and a rising diastolic pressure. Extremities are cool and the skin is very pale and ashen. In that progressive stage, those compensatory mechanisms are functioning, but now they're no longer able to deliver sufficient oxygen, even to the vital organs, and we now have that life-threatening emergency. The client's life can be saved if conditions causing the shock have been corrected within an hour or less, but multiple system organ dysfunction syndrome and permanent damage will occur within a short time without intervention. We see a decrease in our MAP of greater than 20 millimeters of mercury from the baseline value. We begin to see anoxia of the non-vital organs, hypoxia of the vital organs. The overall metabolism is now anaerobic. We have moderate acidosis, moderate hyperkalemia, tissue ischemia, hyperglycemia, hypotension. The client may express a sense of impending doom, confusion, increased thirst, pallor to cyanosis. The skin is cool and moist. Now we see anuria. We have decreased oxygen saturations. And then we move to the refractory stage. At this point, interventions will not save the client's life. Damage will continue despite any interventions we do at this stage. Therapy, including fluid replacement, is ineffective in helping save the client, even if the cause of shock is corrected and the map temporarily returns to normal. The client is experiencing severe tissue hypoxia with ischemia and necrosis. We have a release of that myocardial depressant factor from the pancreas and a buildup of toxic metabolites. We begin to see MODS, the multiple organ dysfunction syndrome, formation of microthrombi that block tissue perfusion and damage even more cells. There's a rapid loss of consciousness. Pulses are no longer palpable. The extremities become cold and dusky. Respirations are slow and shallow, and we have an unmeasurable oxygen saturation and ultimately death. The onset of shock might be rapid or it might be slow, depending on whatever the underlying cause is and the severity of that cause. So, what symptoms might we see in these clients? And we're going to go through this looking at the various body systems. With the cardiovascular, we have a decreased cardiac output. Our heart rate is increased, but the pulse is weak. We have a decreased blood pressure, narrowed pulse pressure, postural hypotension, low central venous pressure, flat neck and hand veins in the dependent position, slow capillary refill in the nail beds, and diminished peripheral pulses. With our respiratory system, our respiratory rate increases, but our respirations are now shallow. We have a decreased PaCO2, a decreased PaO2, decreased oxygen saturation, cyanosis that is seen especially around the lips and the nail beds. With the gastrointestinal system, we have decreased motility, diminished or absent bowel sounds, nausea, vomiting, and maybe even constipation. With neuromuscular, early on the client will be anxious, restless, and report an increased thirst. Later in the progression of shock, we see decreased central nervous system activity, going from lethargy to a coma, generalized muscle weakness, diminished or absent tendon reflexes, and sluggish pupillary response to light. With the renal system, our urine output is going to decrease. In other words, it will be less than 30 mLs per hour or that 0.5 mLs per kilo per hour. That's an early sign of shock. And as shock progresses, we see less and less urine output to the point where we have total anuria. We have an increased specific gravity. Sugar and acetone will be present in the urine. And acute kidney injury can occur after about an hour of renal hypoxia or anoxia. With the integumentary system, it becomes cool to cold, pale to mottled to cyanotic in coloration, becomes moist and clammy. The mouth will be dry with a paste-like coating present. We have decreased capillary refill, in other words, it's slowed down or prolonged, and decreased skin elasticity. We begin to see some CNS changes through restlessness, agitation, anxiety, that feeling of impending doom. With the progression of hypoxia, we begin to see confusion, lethargy, and a loss of consciousness. In the skeletal muscles, we begin to see weakness, pain, decreased or even absent deep tendon reflexes. And then we look at our labs. Our labs are going to show a decreased pH, so we become acidotic, a decreased PaO2, an increased PaCO2, an increased lactic acid, increased potassium, increased creatinine, increased BUN. Our hemoglobin and hematocrit will be increased with fluid shifts and dehydration, but decreased with hemorrhage. The priority problem with shock is inadequate perfusion and the potential for organ dysfunction. This is the Modified Early Warning System, or MUSE. And this is a way that we can determine what we need to do for each level of shock. So with several different indicators such as the respiratory rate or heart rate, blood pressure, etc., it gives us a score, and that total score is going to kind of guide our treatment, basically. And as nurses, as you know, we always like to have something that we can consider measurable. So what do we do for our clients in shock? Well, first of all, especially if you're out in the field, we need to elevate the feet to bring blood to the vital organs. So it's kind of gravity. As you elevate the feet, the blood drains closer to the heart. Keep the client warm. Correct that cause of shock. Make sure that we have that patent airway. We're going to need at least one large bore IV catheter. Assess for any bleeding. We're going to perform oxygen therapy. We can do this through a mask, a hood, a nasal cannula, an endotracheal tube or tracheostomy, but we want to maintain our saturation between 94 and 96%. If our saturation is normal, then we want to not administer any oxygen, but we'll definitely be keeping an eye on it. We're going to do fluid replacement therapy with crystalloids, usually using normal saline or lactated Ringer's, or potentially colloids when we have blood loss to help replace that volume. We may administer drug therapy, giving those vasoconstrictors such as norepinephrine and phenylephrine, inotropic agents, the dobutamine and milrinone, and agents that are going to enhance myocardial perfusion, such as sodium nitroprusside or nitroglycerin, and if they have sepsis, antibiotics. We're going to be monitoring these clients very frequently, at least every 15 minutes. We're going to be obtaining their pulse. And when we obtain their pulse, we're not only looking at the rate, we're looking at the rhythm and the quality. Checking the blood pressure, the pulse pressure, the central venous pressure or CVP, the respiratory rate, skin and mucosal color, the oxygen saturation, cognition, and urine outputs will be done hourly. If necessary, we can correct the shock or cause of shock through surgical management, but only if that's appropriate. Excuse me. Septic shock interventions beyond what we've just covered will include that sepsis bundle. So within 1 hour, we have to measure that lactate level, obtain blood cultures, administer broad spectrum antibiotics, and they may require insulin therapy and anticoagulants. We're also going to obtain some diagnostic labs. We definitely want ABGs because we know these clients are going to go towards the acidotic stage. We want the CBC, our metabolic panel, the lactic acid levels in blood cultures. So what is that sepsis bundle? Within 1 hour of recognizing sepsis, we have to measure that lactate level. If that initial reading is greater than 2, then we're going to remeasure it. We also need to obtain blood cultures, and as always, we need to get our cultures prior to the administration of any antibiotics. Then we're going to initiate broad spectrum antibiotics. And finally, we're going to begin a rapid administration of 30 mLs per kilo of crystalloid fluids. So 30 mLs per kilogram of crystalloid fluids for hypotension or a lactate level that's equal to or greater than 4 for the duration prescribed by the provider. So we may do this for 12 hours, we may do this for 24 hours, whatever the provider prescribes. And apply vasopressors if the client is hypotensive during or after fluid resuscitation to maintain that MAP that's equal to or greater than 65 millimeters of mercury. So let's look at our case study. Jean Kelly is an 82-year-old woman who's been feeling more fatigued the last 3 days and had a fever for the last 24 hours. She reports painful burning sensation when she urinates, as well as the frequency of urination over the last week. Her daughter became concerned and brought her to the emergency department when Jean did not know what day it was, as this was a new onset of confusion. Current vital signs, we have a temp of 101.8. We have a heart rate of 110, but it's regular. A respiratory rate of 24, that's regular. A blood pressure of 102/50. An oxygen saturation of 98% on room air. She has a continuous achy pain, 5 out of 10 to the right flank area. The daughter only recalls the last time her mother urinated was last night around 7:30, 19:30, and it's now 12 p.m. the next day. What do you view Jean's Muse score as, and what do you anticipate will occur next? So let's look at this. We're looking at the Muse scale. Her temperature is on the high side, and when we have the higher temperature, we do suspect, number one, infection, and the higher it gets, the more concerned we are about sepsis. Her temperature gives us a 2, her heart rate a 1, respiratory rate a 2, systolic blood pressure a 0, her level of consciousness a 1, urine output a 0, which equals 9. And this requires observation at least every 30 minutes, and we need to notify that provider for orders. So, do you think this client is at risk for shock? And if so, what is supporting this risk, and what type of shock do you think this client is at risk for? Well, yes, she is at risk for shock. The symptoms or the findings that support this is her age. She has a probable infection, a UTI leading to urosepsis, that increased respiratory rate, decreased to absent urine output, a change in the cognition, mild hypotension, an elevated temperature, and elevated heart rate. So she's probably at risk for septic shock. We now have a 52-year-old male who's being treated for hypovolemic shock that results from bleeding injuries received in a motor vehicle accident. He has a decrease in his MAP of 12 millimeters of mercury from his baseline reading, an increased heart rate, decreased pulse rate, decreased urine output, increased potassium level, mild acidosis. And he states, "I'm so thirsty." What stage of shock is this client in? This would be our compensatory or non-progressive stage. So how does the body in shock cause the pulse pressure to narrow or decrease? Well, shock causes the systolic blood pressure to start dropping, and the diastolic will start elevating, and this causes a narrowing or decreasing of that pulse pressure. So, next question is, what are the priority client problems for the client that are associated with hypovolemic shock? Priority problems: hypoxia and impaired tissue perfusion. So we have that low blood volume. It impacts the amount of oxygen that's available for our tissue or organ function. And confusion, which is caused by poor tissue perfusion, is a safety concern. Anxiety will also increase oxygen demand and slow down the client's recovery. So as shock progresses, what members of the interprofessional team need to be consulted to help address care coordination and transition management? Well, let's look at chaplain services, social services, and case management, not to mention all the members of the healthcare team, such as lab, respiratory, etc. Depending on shock progression, this client may need chaplain services to address spiritual needs. Social services may be necessary to help the family and the patient discuss options regarding the potential needs for long-term care. Uh, Case management would also be involved in that. The client has decreased oxygenation and impaired tissue perfusion. Which clinical manifestations are evidence of onset of the non-progressive or compensatory stages of shock? Select all that apply. Is it decreased urine output? Yes. Low-grade fever? No. Narrowing pulse pressure? Yes. Decreased heart rate? No, our heart rate's going to increase. So E, increased heart rate. Increased sodium reabsorption. Yes. Which client is at risk for obstructive shock? The client with a history of angina, the client with chronic atrial fibrillation, the client with a pulmonary embolus, the client with a history of heart failure. C is the correct answer. The nurse is performing a morning shift assessment on several clients. For which client is the nurse immediately concerned about decreased tissue perfusion if the capillary refill time was delayed? The client with diabetes mellitus, the anemic client, the client with peripheral vascular disease, or the client with severe dehydration? The correct answer is D.